Starting the flow of urine even with straining, weak stream of urine, multiple eruptions, so it starts and stops, irritable urgency, frequency, having to get up a lot through the night, and then even bladder outlet obstruction if the prostate enlarges to that point. So with urinary retention, if there is a restriction there in that urethra, that can cause some urine to be retained in the bladder, right? So some of the symptoms that they can have with that urinary retention could be some of these same clinical manifestations. So frequent voiding, the bladder could be distended because all the urine's not able to be emptied out. They may even have tenderness over the bladder. They may feel pressure that they need to urinate, but then they can't because of some type of obstruction or the size of the prostate restricting the urethra causing that type of obstruction. So, at that point, obviously, if there is a complete obstruction, then it can lead to, and it kind of leads into that too with some of those other complications, with even up to kidney injury, pyelonephritis. So a lot of those problems can really come. So they need to be aware of these symptoms, especially if they're having a lot of the urinary retention type symptoms, so that can be treated so it doesn't develop into something more complicated. So as far as the treatment goes for that, it's really just kind of like watchful waiting. So, they can start them on, we'll talk about some medications just in a minute, but the watchful waiting, active surveillance, those types of medications, tranquilizers, decongestants, those could contribute to some of the symptoms and the clinical manifestations they're having, so they would want to avoid those. The watchful waiting also is going to include them having that digital rectal exam, having that PSA, having those checked on a routine basis based upon the American Cancer Society guidelines as to what age they should begin, and then they should occur yearly after they begin. But that just lets them do the examination of the prostate, give them information to know if it's growing. Well, then if there are some abnormalities in those levels or abnormalities when they're doing the digital rectal exam, then that could indicate that maybe we've got some cancer issues going on, which we'll talk about after this. So that's where they're just going to watch it and see if it develops into anything or if it's just enlarged and stays that way. Some of the specific medications that you will see, page 250 in the ATI pharmacology book. The 5-alpha reductase inhibitors and the prototype in there is finasteride. And really, as far as what the goal, the therapeutic uses is BPH, but you can see the goal of that and the effectiveness of it would be indicated by a decrease in the prostate size, and they're able to urinate effectively. Finasteride. And that's on page 250 in the ATI Med-Surg book. So the 5-alpha reductase inhibitors, alpha adrenergic blockers, some other thing, another medication that you may, and I can't think of I was looking to see if it was in here, but it's not. Flomax, that's another medication that they would use. That's the trade name. I don't know the generic. That's right. Yes. And you've probably given it, but that's another medication. Tamsulosin. Okay. So that medication can, hence the name Flomax. So that does help with the urine flow. So sometimes that can be used for men, especially that are having all of those clinical manifestations, the frequency and then the getting up at night frequently. So those are common medications that can be used. But when you look at that finasteride, there are a lot of, there are some side effects related to that, the gynecomastia, so the male breast appearance, the gynecomastia, that is a pregnancy risk category X. That's always good to know those pregnancy risk categories. And, but it can help with the urinary flow, help with eliminating any type of obstruction and decreasing the size of the prostate. So they can be effective for using effectively used for BPH. FINASTERID. Got it? Okay. So, and it is a smooth muscle relaxant. That can help with, that's what can kind of help with improving the flow of the urine.
You were talking about, on that last part, we were talking about flow gas or finish.
What now?
It's a muscle relaxant.
No, the finasteride. Yeah. So the alpha blockers, the alpha adrenergic blockers act on the alpha receptors, causing the smooth muscle to relax. And I don't know if the book gives a specific example of any of those alpha blockers or not. Finasteride is really the only, and the book even doesn't talk about finasteride. I just know that that's one of those specific ones.
Dr. Caldwell.
Yes.
Did you mention that the tamsulosin, is that the pregnancy risk category A?
No, that's finasteride.
Finasteride.
Yeah, I was just referring, I don't see finasteride, finasteride is pregnancy category X. I don't know about Flomax.
Okay, but it's a prostate medicine? Why do we need to know about, can it be used for something else, or?
Doing it?
The finasteride is medicine for a prostate?
Yes, it's one of the alpha reductase inhibitors that can be prescribed for prostate.
But why does that matter about pregnancy X category?
So, I just made a note because it's noted.
Okay, so it's not, we don't need to
So
like
I would
connect
have
those
to look up something if it would ever be, and I don't know if there is an issue with, fertility, like if you're on this medication, how could it affect it? I'm not sure about that.
Okay.
And I don't know that it would be, I know it mainly being prescribed for prostate, so I don't know that it would be prescribed for a female for any reason, but I don't know if a male is taking it, if that could cause
So
some issues.
I just looked it up, and for women, it can be prescribed for acne and hirsutism.
Okay.
Okay. Okay.
Some kind of weird things.
I don't think that's like a test.
They do, yes, that's exactly right. And the finasteride
question.
specifically can help with decreasing the size of the prostate. So that's out of your book as well, just to kind of give you an idea. But at the point where you have those on the physical exam, you see if they're starting to have bladder stones because of urine sitting in the bladder too long, starting to show symptoms of bloody urine, UTIs, at that point, watchful waiting is no longer appropriate. We've got to do something else. So then that's where surgical management may come in as well. So the TURP procedure is the transurethral incision of the prostate. It talks about that on page 1533 in your book. And you also see an example of it, like before and after, and you can kind of see after, like the prostate's kind of really hollowed out almost. So they resect the prostate, remove a portion of it to allow that urethra to no longer be restricted and allow there to be no restriction of the flow of the urine out of the bladder. So there are some very specific, guidelines as far as nursing interventions go when you are caring for these clients. So there is gonna be a big risk for bleeding. It's pretty traumatic. You can kind of see if they remove that much of the prostate, that it can be, pretty traumatic for the client. So they are going to have bladder irrigation in place. And if you look in your ATI Med Surg book on page 440, that's gonna give you, some good information about that, about the bladder irrigation. So your ATI book, page 440. So under the transurethral resection of the prostate and then post-operative nursing actions, you want to be sure that you want to be sure that you review that, so that way you're aware of how you need to take care of the client. And then you're going to be monitoring the flow. There's going to be continuous irrigation going through, so you want to be sure that there's, when you look at the Foley to determine how much output, you're going to subtract the amount of urine, you're going to subtract the amount of saline that you have irrigated with to determine how much they're actually putting out. So if their output is less than what you're even putting in with the normal saline, the irrigation solution, then you know you've got some kind of obstruction going on, and the urine's not flowing out like it should be. So you're gonna be monitoring it for clots. It specifically says in your ATI book, the rate can be adjusted, and you wanna keep the irrigation to be like a pink or a lighter color. And it said, if, for example, if bright red or ketchup appearing arterial blood with lots of clots is observed, then you may need to increase the rate of the irrigation solution in order to try and clear that out. Because that's the goal, is to try to clear the clots out, so that way it's not obstructing and preventing the flow of the urine out. So that's why you always have the irrigation set up after they go and have that TURP procedure. They are, it can kind of make it does mention there too that the client can complain of the continuous need to void. So with that being in there and the bulb and the fluid and all of that, that could be a normal finding. But you want to be sure that the client is relaxing and not trying to push or force any urine out around the catheter, because it said that could cause bladder spasms. Of course, just like you would with anything, with even a Foley catheter, you want to be sure that there's not any kinks or anything that's going to restrict the flow of the urine and the irrigation patterns. So the TURP procedure, you help open it up, and then you want to be sure you're familiar with that bladder irrigation that's going to be in place after that. The open prostatectomy, that's where they would actually go in and remove the prostate itself. Laser surgery may be another option, and it explains those procedures in the book. But I would say more frequently you're going to see questions or information related to the TURP procedure being used more often than these others. So there's a picture of that procedure, and then the nursing management, you can see that listed out in the book too, but think back to those clinical manifestations we talked about at the beginning, and then we're just gonna continue to monitor for those, like I said, especially if it's a client that they're coming in for routine checkups and we're doing that watchful waiting, then we're gonna be continually monitoring. We wanna be sure that they're not showing any signs of UTI, no elevated temperature, no distension of the bladder, doing the bladder scan to be sure they're not retaining too much urine in there, doing the urinalysis to be sure that it's not showing any signs of any type of infection. And then catheterization, obviously, if it does restrict the urethra to the point that the urine is not able to flow out, then catheterization may be necessary. And then the intervention we talked about. So any questions about those? It's really pretty straightforward, you know. If the prostate grows and restricts the blood, the urine flow, then at the point that it's totally restricted, something further is going to have to be done. So the next topic is erectile dysfunction. And so the issue with this is the inability to maintain an erection sufficient for sexual intercourse. So that's the pathophysiology of it. As far as diagnosis goes, it's going to be based solely upon the patient, their complaint, their bringing this issue to the doctor's attention. And then the medical management, there are several different drugs, and those are also in that same chapter that the finasteride was, but those are the drugs that end in fil. So sildenafil, that's the Viagra, the Levitra is vardenafil. So if you see that suffix, the fils are the ones that are gonna be used for erectile dysfunction. Page 251 in the ATI pharmacology book mentions these medications, and it also talks about other medications that are contraindicated when you're taking those. So when you see these commercials on TV, what do they talk about? If you take, what kind of medications, please discuss this with your doctor. Nitrates, yes. So if you take nitroglycerin, or they have a prescription for nitroglycerin, the client does, and they have this complaint, then it's gonna be contraindicated for them to take the field drugs along with that, because it can cause life-threatening hypotension that could lead to death. So you wanna be sure that their medication list is reviewed to be sure if that's one of those medications, then you wanna be sure. So, because it increases the blood flow to the genitalia area, and then with nitroglycerin, we know that it vasodilates everything, and the combination of those two. I personally, we had a client that, when I worked in the intensive care unit, that had the field medications and the nitroglycerin, and he ended up passing he was an organ donor, because he was a fairly healthy gentleman, but the combination of those two caused him to have a debilitating, life-threatening stroke, and he ended up.
Do you not know about it, like the contraindications?
So I don't know all those details.
Hmm?
Yeah, so, and it could have been, one of those things that it was an oversight.
Yeah.
So that's why it's important for us to be sure that reviewing those medication lists, and I don't know if he had that old medication, and then maybe the doctor started him on something like that. I don't know the backstory behind it, but I know it's real, and it can cause, it can be life-threatening, so you wanna be sure that you monitor that. There are, other, like pellets, injections that can be done, as well as, surgical management. They can actually have the prosthesis. And so it goes into more, details about that, but as far as the nursing care and what we're gonna really be responsible for is gonna be, when we're, doing the medical history or getting the assessment done on the client, the complaints made, be sure the doctor's aware of that, and then monitor the medications that they're on. And be sure that they have the appropriate options. So if they do have a history of heart angina or whatever, that maybe have a prescription for nitroglycerin, and one of these other medical or surgical management options would be more appropriate for them, so they didn't run the risk of those two interacting. Yes.
So you saying if they do have a history of heart angina or anything like that, for it to be on the nitrate, they'll skip the medicine phase and then go to pellets or injections?
Right, it would be contraindicated for them to be taking the field drugs. Yeah. Yeah. And like I said, it goes into it in more detail, but really I would say the main thing that you would need to be aware of is the medication treatment and what we need to be teaching them about with that. And then as it's gonna go through as far as our nursing care, As far as why it may cause neurological or vascular damage, so you think about these people that maybe have been diabetics, these men that have been diabetics, we know the neuropathies that they experience, so it could be a result of something like that. Could be some other type of neurological or spinal injury or something like that. But the health history, their emotional states, we wanna be sure that we are, being aware of their, the psychological aspect of this as well is important. So, and then ultimately, normal healthy sexual functioning is gonna be the ultimate outcome that we wanna get to. So whatever treatment option is appropriate for them, you want that to be successful in them to get to have positive outcome. So prostate cancer, this is where they've gone and they've been doing those digital rectal exams, or they have been having the PSA checked, and then they're starting to identify, okay, well, maybe there's some type of nodule or tumor on the prostate itself. The PSA now has risen above the level of 4, usually is kind of the cutoff. When it gets above 4, then that's usually an indication of something, some abnormal cell dividing and more issues are going on. You see listed there some of the risk factors, so family history, diet can be a factor, consumption of excessive calcium, ODS, high BMI, so the same sort of things that can affect all types of cancer. Obesity, inactivity, diet, those can all play a part in that. The thing about prostate cancer, it's very slow growing. When I worked with these patients, you would always hear the terminology that usually be associated with prostate cancer would be, you die with prostate cancer, you don't die from prostate cancer. So because it's very slow growing, and if it's diagnosed early, it's pretty much, I would say, very, very high cure rate. And I don't know if it says exactly in the book or not, but usually there's a very high cure rate. So they can either come in, we'll get to that in just a second. But the problem with it is because the symptoms are very vague, and the symptoms are associated with, usually men would contribute just to aging. I'm having to get up and go to the bathroom a lot during the night. Those same BPH symptoms, the heart difficulty starting or stopping the stream, the frequency and urgency, and all of those things. So the symptoms can just be written off, and so without routine screening, it can really go, it can be ignored, and then they may not show up until they have their metastasis. So they may show up and have severe bone pain, and it really was the origination of it was prostate cancer, and now it's starting to spread to the bone. So lymph nodes, bone, rectum, and bladder are the normal metastasis, the most common metastasis that I can recall with prostate cancers to the bone. And so most it can cause severe pain, and then if it metastasizes to spots on the spine, then you have all the issues with spinal cord compression and lots and lots of pain to the client. So you want them to be doing being aware of the risk factors and doing the screening early on, so that way they can get treated and avoid the metastasis. So there's a picture that shows the tumors in the prostate itself, and then same sort of clinical manifestations that we talked about with BPH, the diagnosis, higher, like I mentioned to you, getting above 4. Further evaluation for the PSA. If they do identify that PSA is greater than 4, that's when they're going to say, okay, we need to get a biopsy done of this prostate and be sure. And you can kind of see the page 1539 in your book. They use a Gleason scoring system to determine what stage the prostate cancer is in. So Gleason may be a word that you hear associated with the prostate.
Can you spell
GLEASON. So that's how we're gonna diagnose it. There's a picture of the Gleason score, and then the different stages. So obviously, the more progressed stage, the larger the tumor, and metastasis are probably gonna be identified in more. The cancer spread to other organs as the stages increase. The treatment is going to, some will just, especially if it is contained to the prostate, they may come and just do radiation. So usually it requires 6 to 7 weeks of radiation for these clients. The brachytherapy can be used in the form of pellets being actually inserted into the prostate itself, into the tumor. So radioactive pellets to actually destroy the tumor. And so you would just want to be aware that the client's educated about the radiation exposure, so they wouldn't have children sitting on their lap. They would avoid prolonged periods of time with younger children, pregnant women, those radiation precautions that would need to be taken because they would have live radiation actually inserted into the prostate. So, you see others there, cryotherapy, ablative hormone therapy, the chemotherapy is usually going to be only necessary in advanced prostate cancer. So in the clients that come in that have prostate cancer that is already metastasized, who've had it for a long time, those are the ones that are going to need the chemotherapy. Radiation is generally going to be the first line of treatment or the surgical management. Some will opt to just go do a complete prostatectomy, and if it is isolated to the prostate and they're able to get it all. But what we saw a lot of times with the clients that had the total prostatectomy, there would still be some of the cells left, and then they would later have to come back and have radiation because there would be some in the bed of the prostate there would be cancer cells that they would have to come back later to have radiation done. So, they may opt to do the prostatectomy, not want to do radiation. Some would do both at the same time, but surgery and radiation are going to be the primary treatments for prostate cancer, and then the chemo is going to be in situations where it's advanced. The other medication that you may also see used is the ablative hormone therapy. That's using the leuprolide, like we talked about yesterday. Because what it does is used to help with shrinking the prostate before radiation therapy.
Is that the one that decreases like testosterone?
Yes, exactly right. Suppress the testosterone. So we talked about it with the women, suppressing the estrogen. So with the men, it's going to suppress the testosterone, shrink the prostate, and then make it easier for them to remove it when they do have the surgery. So we talked in detail about that yesterday. You know what page it's on in the ATI book to be familiar with the symptoms that the client may be experiencing. And they can have all those same symptoms. They can have the hot flashes. They can have all those same symptoms that the women have. Talking about the surgery, the radical prostatectomy. Again, after the radical prostatectomy, bladder irrigation is going to be one that is going to have to be mentioned. I think that post-operative surgical care, you see that in the book. The bladder irrigation is going to help removing the blood and the clots and everything. And so refer back to that same page that we already talked about to review the bladder irrigation.
I have a question.
Yes.
Will the bladder irrigation be like continuous or like manual? Like, cause I've seen them in the ER be continuous and I've seen them be manual.
Usually it's continuous,
Okay.
especially after a surgery like that, and they know that it's gonna be an ongoing issue with the clots. Yeah, we always did it continuously, where it's be hooked up to an IV. You have a certain type of, indwelling catheter that has the extra port, and you can hook the IV tubing up to create continuous irrigation. I did kind of mention to you too, they do have the brachytherapy, the precautions that we would need to take with the radiation. And then also talking to them too about the prevention, being sure that if you're caring for clients that are over the age of 40 and they're kind of entering the years where they're gonna that get the PSA screening done and the digital rectal exam, but don't quote me on that. I'm not 100% sure, but it'd be one of those things too, you know, I mean, if someone has a family history, they can always opt to say, even if insurance doesn't pay for it because the American Cancer Society doesn't say I don't need it till whatever age, if there's a family history, that's something they can always be proactive about, having the screening done to try to prevent that. Another prevention thing, increasing the omega-3 fatty acids, like for example, what may be found in tuna fish, that can be helpful. It does mention some other things, selenium, oysters, tuna, whole wheat bread, sunflower seeds.
Are you making a book or busy?
That's in the med-surg book when you're looking over under nursing management. Yeah, it's right there in 1541, yeah, page, well, it's under nursing management, different page.
I see it in the prevention, where it says teaching, and it says prevention.
Yes, and it talks about, what encouraging them to eat those foods, yeah. And it's the omega-3 fatty acids that are good for them. That can be helpful. So any questions about prostate cancer? We're gonna move on to testicular cancer, and where prostate cancer is diagnosed more in the older population, testicular cancer is gonna be the young adults, even teenage years can be more predisposed to this. I was gonna look and see exactly in the book, but I would probably say even between around, it says it has increased, I was gonna try to see the age exactly.
15 to 35.
That's what I was gonna guess at 15 to around 30, so 15 to 35. So you can tell this is very much an issue in that younger population. And the pathophysiology, the testicular cancer actually begins in the testicles, and it can spread through the blood supply, metastasize to the lymph system. And usually the complaint is just that they have a painless mass. Sometimes that can, I've known of individuals too that did have pain with it, but the textbook typical is a painless mass that they're able to identify on the testicle itself. So there's a picture of it right there, you can see the mass or, and then physical assessment, can it be, part of the diagnostic, actually palpating the tumor itself, ultrasound, doing lab work, and there is I was pretty sure that there was another one of those like cancer markers, but I don't see it here in the book for the testicular cancer. But as far as the treatment is gonna go, usually surgical removal of it, and if it's isolated there, no spread or anything, they remove the testicle that is diseased, and then a very, very high cure rate if it is covered. What now?
What test? Or we still have the same?
So if they are, if they're young, which they are, between 15 to 35, and they are gonna have to undergo, treatment for this, then they usually are gonna have some discussions about the, necessity for the possibility of sperm banking or something. Because that could be a factor, especially if they have to do radiation chemotherapy, it could be more of an issue with the destruction of with the destruction of the sperm and all, that could ultimately cause it to be fertile. Yes.
The book says that the tumor markers are alpha-fetoprotein and HCG.
Thank you. So AFP, the alpha fetoprotein, yeah. So I knew that there were some that would be significantly elevated, and then they would kind of monitor those too throughout the years as they're coming back for, reassessments. Yes.
Okay, so going to the fertility part of it, my brother-in-law had testicular
Uh-huh.
cancer when he was probably in his early 20s, and he has 5 children.
Okay,
Yeah.
so did he just have surgery?
He had surgery, and I don't know if he had.
Did he do anything
Well, I
else?
think he did because it.
Steve from Sex and the City
He
only
doesn't
has
have
one
any
wall.
lymph nodes at all.
Okay,
Huh?
so they removed the testicle and also the lymph nodes that were affected as well. So you think he did chemo radiation too? You know if he did sperm banking?
No, he
Or they did not?
No, they're all from naturally.
Yeah, no.
And it's fine.
So he had zero issues? Zero issues procreating. Wow, okay. So that is something that you may see come up though, and I was gonna see if it is in the, if it does kinda come up in, yeah, sperm storage. It does say that that could be part of your teaching notes, that encourage the patient to bank sperm before treatment should the patient wish to preserve potential fertility. So, may or may not be.
I don't know if it was an oddity for that to happen or not.
Yeah, but if they do go ahead and bank the sperm, then that would be pretty much a guarantee. You know what I'm saying? That way, if it is destroyed through the surgery, through the treatment,
Is that
then
the
they would
same
have
as
to.
like breathing over?
Yes, I think so. Yeah. So like I said, but usually that treatment, removal of the affected testicle, that's usually all that's necessary. The clinical manifestations, so this is where, also with our teaching, we are gonna wanna be sure that we talk to them about, prevention-wise, males doing the testicular self-exams. So, and I did post there's one posted under this module too, for the breast self-exam, as well as the testicular self-exam. They say that for the males, it doesn't matter what day of the month, they need to be doing it on a monthly basis. And then after the shower would be the time where it could be palpated the best. So that's when they should be encouraged to do that. Also for the females with breast self-exam, you wanna be sure that they are doing it, the women they're still having a menstrual cycle every month. The week after their menstrual cycle, where the breasts are not so tender and maybe not having, hormonal changes. So the week after is an appropriate time. And then for women that have already been through menopause, they can do it any day of the month. It doesn't matter, but it's good for them to pick a day that stands out to them. So maybe, for example, if their birthday's on the 15th of the month, maybe they said, okay, the 15th of every month, I'm gonna be sure that I'm intentional about doing a breast self-exam. But they can do it any time of the month. It's just the ones, the clients that are still going through a menstrual cycle are encouraged to do it the week after their menstrual cycle. Because of the tenderness and things that they can be occurring through. So just review that module, just review that picture in the module to be sure that you would know how to educate them about doing the breast self-exam as well as the testicular self-exam. So, and then after, as far as follow-up goes, this is something they're gonna have to continue. They were diagnosed with testicular cancer, they had surgery. Because of there is the potential for some recurrence, they're gonna have to continue to do follow-ups. There's gonna be every 6 months for so many years, and then every year after that for a prolonged period of time. A lot of times too, that follow-up may include like having a CT scan just to be sure that there's no mass or lumps or any other, weird activity that's showing up that can indicate that there is any type of recurrence. So any questions about that? Those are pretty straightforward, with all of them. But early diagnosis is the key, and like I said, if they're doing the, just like with breast self-exams, if they're doing the routine breast self-exams, they can identify the lump early, same with the testicular self-exam. So male breast cancer is the next one that we're gonna discuss. And you're gonna see similarities between you're gonna see some similarities between this one as well as the female breast cancer. One thing particularly about this, you do see it mentioned there, the advanced age is more of a risk factor for the male breast cancer. If they have family history, excessive alcohol consumption, there can be environmental factors, hormonal imbalances, because just like with the females, the hormones do play a part in this cancer, in feeding the cancer cells. Some others, there can be some rare genetic conditions that can make them more predisposed to having breast cancer. Pathophysiology is the same for all the others. The clinical manifestations are gonna be the same as it was for the female. They're actually gonna be able to palpate. There's gonna be a tumor, there's gonna be a mass there in that breast tissue. And then an examination, a physical exam can be, the first step of diagnosis, as well as the ultrasound and then the MRI. So, no, mammography is not gonna be an option because the males only have a small amount of breast tissue this could occur in, would not be appropriate for them to have that. But ultrasound or MRI can be used with the diagnosis. It does talk about the more common one that men are usually diagnosed with is the ductal carcinoma. And those are the ones that are, less likely to spread to the lymph nodes. It does mention that there are some that may have the inflammatory breast cancer, which would be a little more, which can be more aggressive than the ductal carcinoma. So the treatment, same options pretty much that you saw for the female. So surgical removal of the tumor can be appropriate, chemo, radiation, and the radiation again, same types of symptoms. We know that it's gonna be localized symptoms in the area that's actually being radiated. But they do also, the surgical resection, it could be a resection of just the tumor itself, but it may also be called more of a radical mastectomy because it may, especially if it involves removing the breast tissue as well as some of the lymph nodes. So again, they would have to check and be sure, do the biopsy and everything, if the lymph nodes are affected. And then you'll also wanna be cautious with the males, the symptoms of lymphedema, if they have those lymph nodes removed, all of those same teaching and interventions would be necessary for them, like protecting the arm, the sleeve to help with promoting the circulation and the drainage of the fluid in all of the arm, all of those would be appropriate for them. And the treatment is largely gonna be based upon when's it diagnosed, what stage it's in, all of those things are gonna guide what treatment is. So with the clinical manifestations, that's what, physical exam, we're gonna be, you think about your nursing management, they come in and they have that complaint. If they have to have surgery post-operatively, we're going to be doing the same things that we would for any surgical client. Monitoring all the vital signs, airway, circulation, all of those things. Monitoring the incision, being sure that it's not bleeding profusely. Being sure that their pain is treated. And the drains, they may still have to have the JV drains as a result of the amount of tissue that is removed, especially if lymph nodes are involved. So you want to be sure that you are monitoring those drainage. When you empty the drain, remember you always have to squeeze it back tight and put the cap back on it, because if you don't have, then it's not going to have any suction on it. So you want to be sure that it's empty it and then squeeze it back and then put the cap on it. And then monitor it, starts to fill up. You want to be sure that you empty it because it's going to lose its suction and it's not going to be doing its job with pulling that extra fluid out of there, so that way it can heal more quickly. And then that's mostly just monitoring the incision site, You know, we're gonna look for warmth, redness, swelling, any break in the incision or trying to open up. Looking to be sure that there's not any type of drainage or anything that, would show any type of infection. But again, the men need to be doing a breast self-exam as well. Any time of the month would be appropriate. Keep follow-up appointments. And then our ultimate outcome would be good surgical site healing, hopefully it can take cure from the cancer itself. Okay? So we'll go ahead and stop, we'll take our break there.